Morning. My name is Jay Rajda, and I'm with the Innovation Labs at Aetna. Aetna's Innovation Labs is charged with identifying new ideas and new programs that can improve the quality of care and reduce the cost of care for our members, and thereby deliver value to our clients. The last few years have been interesting with a shift away from fee-for-service towards value-based care, and innovative financial models and provider reimbursement models do a great job of aligning provider incentives with the overall quality and cost of care. But to really improve quality of care, patients and providers need to work hand in hand. Adding patient incentives into the value-based care model could make the model very powerful and very effective at driving improved quality through better patient engagement. A few months ago when I met Matt Loper and his team at Wellth, I was very excited to learn that the team was working on solving exactly this problem. So with no further ado, here's Matt from Wellth.
Thanks, Jay. Good morning, everyone. It's been great to partner with Jay and the rest of his team at Aetna. In my opinion, Aetna is the most forward-thinking payer in terms of rethinking their traditional business model from fee-for-service to fee-for-quality and value. So it's been great to get their mentorship and advice. This is Kobe Bryant. When I was a kid growing up in Southern California, I idolized this man. I wanted to be just like Kobe. So naturally, I needed his sneakers. These are the Adidas Crazy 8s. Today they may look bulky and ugly, but back then they were the epitome of cool. I wanted these shoes so bad, I kept begging my father, "Dad, I need to play more like Kobe, please get me these shoes." There was one big problem. These shoes cost $100, and my weekly allowance was about $3. So eventually my dad broke down. He's like, "All right, I will make a deal with you. If you get straight A's this year, I will buy you those sneakers." And guess what? Here's my real report card from 6th grade. I was able to get straight A's. At the end of the year, my dad bought me those shoes, and I wore them out that summer. So some people might say my dad bribed me, but I like to use the term incentive. And this is exactly what's going on in our healthcare system today. As we shift to value-based care, payers are providing incentives to providers to produce better quality, lower cost care. At Wellth, we love this concept, but we think it's leaving out the third and most important stakeholder, the patient themselves. In order to have a successful ACO, you have to get patients to improve their behaviors and their health. So that's exactly what Wellth does. We let payers and providers who are adopting value-based care pay patients financial incentives to take better care of themselves. How do we do this? Well, we have an analytics system that would work with our customers to analyze their specific patient population and their specific value-based care contracts to determine the highest value behavior changes amongst our patients. And then we would serve these behavior change programs through our mobile application directly to the patients themselves. So let's say we're working with you and you run a fairly large ACO here in New York City. We see that you have a lot of out-of-control type 2 diabetics in your population. And we also see that you have a lot of incentives to get those patients better and healthier. So we would work with you and design some incentive plans and roll them out to patients like Mary. Mary is a type 2 diabetic. She's been sitting behind this desk for 25 years. She also has hypertension. Her type 2 diabetes is poorly controlled. Her HbA1c is about 9%. She hears about this new app that you are providing to pay her to take better care of herself. So she downloads the app, and it's extremely easy to use. She's able to log in and immediately be shown her goals for this year. So it's very important of how we actually serve these goals to Mary. So we set the long-term 12-month goals. Mary, this year we want you to decrease your HbA1c and your blood pressure. But we know if we just did that, there's a good chance a few weeks from now, it's no longer top of mind, Mary reverts back to her old habits, and she doesn't actually improve. So what we need to do is we need to take these long-term goals and parse them into the individual tiny habits that get reinforced on a daily basis to reprogram her habits and get her to these long-term goals. For example, we want Mary to improve her blood pressure. Every day we send a push notification, Mary, it's time to take your blood pressure medication. With one click of a button, she's able to open the app, verify she's taken her pill, and immediately get this positive reinforcement. Great job, Mary, keep it up. You're on the streak of 27 straight days. Over the course of 6 months, she takes her pill, we establish this habit, she actually improves her blood pressure, she goes back to see her doctor, and we're able to pull the data directly from the EMR. Boom, great job, Mary, you just hit your big goal, keep it up. In the same vein, we want her to decrease her blood sugar volatility. So 12-month goal, Mary, improve your HbA1c. Every day to do that, check your blood sugar after every meal, upload the results. And we reward not only the habit of uploading those results, but also provide her her own data so she can better manage and track her diseases. Over the course of time, she goes back and gets her HbA1c result. She can snap a photo. We can pull the data directly for her and input it. So Mary's now happier and healthier. For the first time, she feels like she's actually in control of her health. And she's earned a significant amount of financial incentives back from you. But most importantly, she's had a great experience with you, her provider. And that's really our goal, to help our customers achieve better health and better wealth. Our team is from a varied experience, ranging from technologists at successful startups to PhDs and MDs to former actuaries at big Blue Cross Blue Shield plans. But the one thing that we all have in common is that we all are from a science or engineering background. And this guides us in the way we do our work. Everything we recommend is evidence-based, and we are very focused on objectively providing data that shows our value. We're also advised by some thought leaders in the space. Dr. Mark Fendrick, he's kind of like the Kobe Bryant of value-based care. He's at the University of Michigan. And Larry Hauser, he's in the back today. He's the former head of the American Diabetes Association. We're extremely grateful for the experience we had through the NYDHA. It's been a fantastic program. We were matched with not only Aetna, but also Medisys, G-Bon. I see Dr. V in the audience today. They have all been great people to work with, great organizations to learn from, and we're actively in discussions with a number of pilots with all these groups. Speaking of pilots, we just finished our first one, which was sponsored by a large national health plan. And we looked at the daily medication adherence in type 2 diabetics. We had 114 patients randomly assigned to either a large incentive or a small incentive group. And we were able to show that the significant financial incentive produced a 78% increase in daily adherence to those medication check-ins. This is just the first step for us. We're in discussions with them to move to the next step of implementation, and we're really excited to take this initial results and prove it out on a larger scale and in more outcomes-based data. So I know what you're thinking. This all sounds great, but where is this money coming from? Well, if you look at the Medicare shared savings data from their MSSP program, 74% of ACOs last year made $0 in shared savings bonuses. So this means the vast majority of the ACOs in this country are leaving millions and millions of dollars on the table. So our goal is really to help our customers make as much money in shared savings as possible. And since you're only paying out patients who improve, you're just going to take a tiny portion of those year-end bonuses and use it to fund those incentives. Here are the specific interventions that we currently are working on in diabetes, congestive heart failure, COPD, and asthma. All of these programs are designed to directly impact near-term utilization, costs, hospitalizations, and ER visits. Our actuaries put some numbers behind them using very conservative assumptions and cited cost savings data from the literature. We show a very strong ROI in all these cases. This is on a per patient level. If you're talking about an ACO with 50,000 lives with about 50% shared savings, here's what we would estimate in terms of ROI in a one-year time frame. In the fundraising side of things, we're currently raising around. It's being led by the strategic venture arm of AXA, which is a large insurance company. We're very excited to have someone strategic who's a potential customer leading our round. We're expecting initial close tomorrow, actually. So we're extremely excited. This gives us 2 years of runway to execute some of these large implementations we have in our pipeline. So today we shared with you our vision for the future of value-based care, one in which everyone has skin in the game, including the patients themselves. We showed you what we think your ROI would be if you were to implement this. So if you're a payer or provider thinking about your value-based care strategy, we'd love to talk to you. Please feel free to see me after the end of these presentations or reach out to me directly. Thank you very much.